You just let me know when you want me to start. Like I can just start now.
Uh, so we can start, I think. Everyone join. Yeah.
Yeah, okay, cool. So next we look at acute eosinophilic pneumonia, mainly because this is one of the more treatable ones. So important thing is acute eosinophilic pneumonia is going to be presenting very much like an infection, right? So usually the symptoms occur less than within a week. So you have non-specific symptoms of cough and dyspnea. Less frequently, you have malaise and some sort of, constitutional symptoms like night sweat chills. And rarely you can have fever as well. Important thing to note is young patients, 30-year-olds, male predominance, previously healthy young adults, and 2/3 of the patients are smokers. So, if they have some sort of a change, basically these patients have a trigger and then they develop like an acute eosinophilic pneumonia, right? So either they've just started smoking, they've increased their smoking, or they had stopped and restarted their smoking and smoking large quantities of cigarettes. This is when you're kind of thinking about acute eosinophilic pneumonia. So, and you have some environmental triggers. You have some illicit drugs, viruses, parasites. All of these can cause like an acute eosinophilic pneumonia. Drug-induced lung injury can also present like acute eosinophilic pneumonia. We'll come to that just a little later. So like I said, this history, the change in smoking is something that we don't really go to. It's more of like, okay, how much have you been smoking? How long have you been smoking? No one really goes into the depth of, whether you change smoking and so on. And this is not going to come initially as well. So this is going to be retrospective. Most of the times, what happens is you're going to do a BAL, you're going to find eosinophils, you're going to say that this is acute eosinophilic pneumonia, then you're going to go back and get this history, and then you kind of realize that, okay, oh, this actually happened. So it's, I guess you can't do anything about that, to be honest. You do have some diagnostic criteria where you have a febrile respiratory manifestation, like I said, non-specific symptoms that occur less than 1 month, especially within a week. Bilateral diffuse opacities on imaging, you have basically meeting ARDS criteria with a low PF ratio. The most important thing is that BAL eosinophilia is more than 25%. So you do a mini BAL, you do a BAL, and you have like rich BAL rich in eosinophils that fits the AAP diagnostic criteria. So normally what happens is a normal bronchoscopic alveolar lavage will have about 85% of alveolar macrophages, followed by lymphocytes and then neutrophils and so on. In proper ARDS itself, the BAL is going to be neutrophilic. The amount of neutrophils is going to increase. And the same is the case with acute interstitial pneumonia or with, bacterial pneumonia, infective pneumonia, and so on. But in acute eosinophilic pneumonia, you're looking at BAL eosinophils, which is more than 25%. Apart from this, you don't find any other cause of pulmonary eosinophilia, like you look at drugs and you look at any infections, parasitic infections, and so on. And that is how you kind of diagnose acute eosinophilic pneumonia. Another very important thing to note is the peripheral eosinophilia is not going to be present at baseline. The patient comes to you, you don't find eosinophilia, doesn't mean the patient has AEP. AEP is known by the fact that, the blood eosinophils rise only later, maybe few weeks after the illness has started. So that is very important. No blood eosinophilia, but a lot of BAL eosinophilia. And it is very, very steroid responsive. If you look at it, you have pulmonary infiltrates, and the X-ray actually improves within a week and almost normalizes within 4 weeks. This is how AEP looks. It has different, radiological pictures. I've just put this up because it can help with the others as well. So this is bilateral ground glassing, and this is what you call a subpleural sparing. This is what I was talking about when we were talking about diffuse alveolar hemorrhage. This subpleural sparing may not always be there. Even in DH, it's going to be there only in a minority of patients, maybe less than 25% or something like that. You can have consolidations, you can have interlobular septal thickenings, and you can have bilateral mild pleural effusions and some amount of nodules. But this is just for information. Usually, we're talking about the patients who present just like an ARDS with bilateral consolidations, right? So treatment, again, IV MPS followed by tapering regimen. These people respond excellently to steroids. So within a week, you're kind of getting them extubated and they're doing very well. And in the absence of respiratory failure, you can always do an oral prednisolone. But I mean, yeah, you need to do this, or you can, if you can stop the inciting agent itself, if it's very mild, that will help. So AEP is one of the most important mimics that will have to be remembered apart from the DH. Hold on, I've just got a chat. Sir, if no peripheral eosinophilia, when should we even start thinking of AEP in a patient in the ICU? What are the red flag signs? So that's a good question. Like I said, red flag signs are any signs in ARDS where you don't have a risk factor and the timeline is not fitting. Say, okay, fine, forget the timeline. Even if the timeline fits, you're not having a witnessed aspiration. You're not able to find what is that infection. That is when you kind of start thinking about all of these. You can't say that, okay, I am thinking of AEP. That is not how ARDS differentials are going to work. ARDS differentials will be more like, okay, what do I need to do next? Next is going to be bronchoscopy. This is why bronchoscopy is going to be extremely important. Only after that, in retrospect, you'll be able to diagnose AEP. Otherwise, like I said, clinical features might just point you towards it. Say a young patient suddenly came with this, you might think about it, but otherwise, most likely it is going to be retrospective. So coming to acute interstitial pneumonia, this is also called as Harmon-Rix syndrome. This is one of the most, how do you say, depressing of the pulmonary syndromes, right? So this is an idiopathic lung injury characterized by diffuse alveolar damage. This is basically ARDS, but without a known cause of ARDS. You have admitted the patient, you've done a complete infective workup, bronchoscopy, and everything. You're not finding anything that is coming up, autoimmune serology, everything is negative. Then you kind of label the patient to have an acute interstitial pneumonia. So the diagnostic criteria is basically the diagnostic criteria of ARDS, followed by a histological documentation of diffuse alveolar damage, right? But there is a problem here is most of the patients of AIP are not going to have a histologic diagnosis because we don't do lung biopsies that frequently. Mostly, we're just going to do a BAL and we kind of stop and we label the patient to have acute interstitial pneumonia, right? So this is a problem. So the problems that have come up is one is, yeah, we don't do a biopsy. And the second thing is a CT scan, right? We see a CT scan and we're like, okay, we have the information. Why even do a biopsy? This is kind of a problem because a lot of patients who have been labeled AIP, uh, and autopsy studies have been done, and some of them have actually come out to have a different diagnosis, like adenocarcinoma of the lung. So it is really like just a blanket term. You're going to use AIP as ARDS, which is idiopathic, but you can never really be sure that it is acute interstitial pneumonia. And this is quite depressing because it happens in young, healthy people, 40, equal sex distribution. Most are, about 40 years, mean age of 50 years, quite okay. It is not even associated with smoking. And the worst part is more than 50% of them are going to die. So before labeling a patient as AIP, which is essentially a diagnosis of exclusion, make sure that you have actually done your due diligence and make sure that you've ruled out every other thing that is possible. And the worst part is there's no treatment. You just do a mechanical ventilation supportive treatment. People are treated with steroids, but it doesn't really help. It's quite, it's just a depressing condition. So next would be a rapidly progressive ILD and acute exacerbation of IPF. I put in rapidly progressive ILD because this was initially supposed to be the topic of the talk. So we'll just do a brief about what it is, and then we'll move on to acute exacerbation of IPF. So rapidly progressive ILD is basically, acute and progressive worsening dyspnea that occurs within a month, and that can either have, respiratory failure or decline in lung function, or HRCT showing increase in interstitial abnormalities, or an ABG showing respiratory failure or reduction in partial pressure of oxygen. So this definition of RP-ILD, like I said, so if you have an FVC and DLCO that is falling, if you have interstitial abnormalities that is increasing, this means that you have a basal diagnosis of something wrong with the lung. You have a previous PFT, you have previous HRCT showing some interstitial abnormalities. So that is when, you can actually say it is RP-ILD. But acute exacerbation of ILD can very much present as ARDS, can be the first presentation. I'll just talk about that in the next couple of slides. So when you're looking at a rapidly progressive ILD, you're looking at myositis-related ILD, acute interstitial pneumonia, drug-induced ILD, radiation-induced ILD, and acute hypersensitivity pneumonitis. So these are some causes where, the lung disease actually rapidly progresses. And here is where clinical examination actually becomes important. Apart from DAH, ILD is where clinical features actually help in ARDS. You can have Gotron's papules, a heliotrope rash, Raynaud phenomenon, mechanics hands. These are all pointers towards some sort of autoimmune disease that's going on. And importantly, radiology might help here in cases where, especially MDA5 and certain other myositis ILD can present with spontaneous pneumomediastinum and pneumothorax. So if you have an ILD patient who comes in, or, the clinical features would most likely be like a woman in her 40s, or, something like that. You may not have a previous history. If you still think that after an extractable nuclear antigen panel or an ANA comes negative, you still think that, okay, maybe this could be myositis by the way it is progressing, it is worthwhile to do a myositis panel, or at least a screening LDH, screening creatinine kinase, where those enzymes will be elevated, and that can prompt you to do a myositis panel later. So acute exacerbation of ILD is again another thing similar to RP-ILD. They kind of, can be clubbed together, I guess. So we have defined goals and defined a definition for acute exacerbation only for IPF and not other ILDs. The other ILDs, acute exacerbation, we kind of take it from the IPF itself. This may be the first manifestation of ILD. So any ARDS, you have to do a serologic marker. So autoimmune markers in the setting of acute inflammation or systemic inflammation may be unreliable, but if you're getting like strong signals of, say, ANA, strong signals of some ENA marker, it would be worthwhile to help in diagnosis of an acute exacerbation of ILD. And if it's their first presentation with no background ILD, they might actually completely improve also. Okay, so we're talking about this, like I said, we'll just go into the IPF and I'll discuss then. So when you're looking at an acute exacerbation of IPF, you're looking at an acute deterioration. And similar to ARDS, you rule out other causes like pneumothorax, pleural effusion, pulmonary embolism. And you have these new GGOs, new consolidation of on the CT. And then you can diagnose the acute exacerbation of ILD. Acute exacerbation of ILD has very similar triggers like normal ARDS. Infections can trigger, drugs can trigger, aspiration can trigger. So, even when you have a trigger like an aspiration or something like that, and an infection or a viral infection especially, it may be worthwhile to test for autoimmune markers because the triggers are so similar. If you're not able to find a trigger, it can always be just a self-autoimmune trigger kind of thing that's happening. So if you look at the definition, actually, you should have a previous or a concurrent diagnosis of IPF. This is for idiopathic pulmonary fibrosis, need not always be the case. Sometimes in the CT, apart from the consolidation and GGOs, you can have some honeycombing and tractional bronchiectasis, something to say that something chronic is happening in the lung. But otherwise, not really. You can just have an ARDS presentation. You have worsening symptoms for 1 month, bilateral GGOs, and deterioration not fully explained by cardiac failure or cardiac overload. I put this up here because you can see that, apart from the previous or diagnosis of IPF, the definitions are so kind of similar to, ARDS, except for the time duration that is happening here. So it is very important to keep in mind that most of these mimics are going to present exactly like ARDS. The problem with management of acute IPF is no control data. I mean, we do now have data saying that you can't use cyclophosphamide and so on. But the usual treatment is pulse corticosteroids followed by 1 mg per kg. And these patients actually do well. So the takeaway from this would be that even if you have a trigger, it may be worthwhile in a proper setting if you're not having an infection or something like that to test for autoimmune markers to just make sure that, okay, this patient is not having an autoimmune ILD kind of thing where they might require higher steroids. One of the last ones we'll talk about is drug-induced lung injury. The only thing I want to kind of stress upon here is Pneumotox. This is like an excellent online resource. I'm sure, most of you would know this. So this is an app where people put up all the kind of drug-related lung manifestations that can be there. So if you find any patient on any drug, you just put it in there and then see if it can cause ARDS. So we had a patient who was like, stage 4 breast cancer, had received multiple chemotherapies, then it worsened, and then she was put on a couple of oral drugs. I can't even remember the name. And then she developed a fever and worsening respiratory symptoms, CT looking exactly like an ARDS. We had to intubate her, but on intubation, we found that the BAL was negative for viruses, negative for bacterial genes. What we did was we labeled her as a drug-induced ILD because one of her oral chemotherapy was started recently, and then we gave her pulse steroids and oral steroids, and she improved. So even if the clinical picture looks very much like an infection, like fever or fever, pneumonia, ARDS, it would be worthwhile to do a lower respiratory tract sampling just to rule it out, especially if you think that, okay, the patient is young, salvageable, and, there it would make real good sense. The problems with drug-induced ILD or drug-induced ARDS is so many. One is it is very non-specific. It can either be acute, chronic, or subacute, anything. One is it is dose independent. So it's not really like, okay, you up the dose and it happened now. It can happen at any point in time. It is idiosyncratic. It can have a variable latency in drug initiation. So even months after drug initiation, it can be precipitated. You have a lot of radiographic patterns. We'll talk about that later. And resolution usually occurs once you stop the drug and then you don't re-challenge it. So like, if you can look here, it is so vague, so vague. So one of the best things to do is just go back to the history. If you look at any drug that's, okay, even a little fancy, I guess, you have to think of it as a possible cause of ARDS. One thing that can help is, in drug-induced ARDS, if you do a bronchoscopy, it will be lymphocytic. That can kind of help to kind of go away from the diffuse alveolar damage, neutrophilic BAL picture, ARDS kind of thing. But like I said, just remember, this is very vague. It is a diagnosis of exclusion. So some drugs do have a dose-dependent toxicity, like amiodarone, bleomycin, and mitomycin. You have some underlying ILDs like RA-ILD, systemic sclerosis, which can precipitate or be a risk factor for drug-induced ILD. If you combine pneumotoxic drugs, especially chemotherapies or other radiation and immune checkpoint inhibitors, that can increase your risk of drug-induced ILDs. So if they have a background oxygen requirement, they can again be precipitated. And like I said, re-challenge is not recommended. And it is very important, especially if it's an oncologic patient, to discuss with the primary team to actually see if it is, re-challenge can be done, or if they can look at different therapies. So radiology, like I said, can be very, very varied. Apart from presenting like an acute ARDS, the radiologic picture itself can have NSIP, OP, alveolar hemorrhage, eosinophilic pneumonia, diffuse alveolar damage itself, or sarcoidosis. So basically, any and every ILD kind of pattern can be related to a drug. So drug history becomes extremely important. Just a word about immune checkpoint inhibitors, because these are known to cause pulmonary infiltrates and pneumonitis. You can have small, grade 1 reactions based on the WHO grading or CTC grading. Then you can just give them like stopping the drug. Or if it's of a higher grade, you again go in for steroids. This would kind of be similar to other drug-induced ILDs, where steroids is the mainstay of treatment. Prednisolone 1 to 2 mg, tapered slowly over 4 to 6 weeks. Or grade 3, you can give them pulse followed by oral steroids. Like I said, very high steroid dose help these patients. So just miscellaneous, I'm going to talk about just one thing. If you look at this image, it's, you're rarely it's very difficult to say that it's cancer. It can very easily be, so many other things, right? So you have something called as a mnemonic type of adenocarcinoma that is just going to present like this. Bilateral consolidations, that is here, maybe some crazy paving pattern, some GGOs with nodules over here. It, just bilateral consolidation, very rarely some mass-like consolidation over here. So pneumonic type of adenocarcinoma or a lymphangitic spread can also very much present as ARDS. So we had a patient who was again treated for breast cancer 4 years prior, off chemotherapy, off radiotherapy, came with just 2 weeks of dyspnea and cough, came with a respiratory failure. We intubated her. Imaging showed just bilateral consolidation, very much like an ARDS picture. Discussions with radiology could not find out anything. BAL biofire negative, BAL cytology negative, nothing positive. Finally, she kind of, we gave her steroids, just empirically thinking, okay, it might respond because we had no other option. And finally, she expired. We did a we did a minimally invasive tissue sampling, and we found her to have lung adenocarcinoma. It was very unexpected. And if you hear any pulmonary podcast, that is all they're going to tell you. Oh, okay, they came in with ARDS. They died, and then they showed lung adenocarcinoma. We were shocked. That's how it's going to be. It's you have to suspect it. But one thing is, mnemonic type of adenocarcinoma can show up on BAL, right? So sputum or BAL cytology or repeated mini BAL cytology can pick up malignant cells, and this is very important. It is very important as goals of care because then you're going to start palliating the patient. Usual presentation of such patients are okay, prolonged subacute course, like a non-resolving pneumonia. But like I said, there are cases that present acutely within weeks' time, 1 or 2 weeks. But these patients are usually older, significant smoking history sometimes, and so on. So I'm just going to come to the end of the talk with that. The most important thing is just know that not all bilateral acute severe lung disease is ARDS, even though once you put them on a ventilator, they're going to fit the Berlin criteria. It is not ARDS, okay? That is just a physiology. The actual cause is going to be different, and it's important to find that cause. It is always important to suspect ARDS mimics because it can change management and prognosis. Like I said, what we're looking for is steroid responsive diseases or diseases where you can end up palliating the patient. I haven't spoken about infections like PCP or general pneumonia or VAP causing ARDS because those will usually be picked up. I just want to focus on the inflammation and malignancy part of it. The next thing is investigate thoroughly. Don't think at any point of time that the patient is sick, because by avoiding a BAL, you may actually be preventing the patient from getting life-saving treatment. Because giving high-dose steroid is always a risky game in the ICU, especially when infections are so high. It's always better to have a diagnosis, at that point of time. So I think with that, I'll just kind of conclude my talk. If anyone has any questions or anything they would want to ask or want to talk about any other
Hello,
mimic or disease.
sir.
Hi, yeah.
Hello.
Yeah, hi.
Sir, I'm Aditi, sir. I'm medicine final year PG. I actually had a couple of doubts.
Yeah,
Hello.
go on.
Sir, if a patient comes after a road traffic accident with multiple, like even limb fractures,
Mm,
and maybe rib fractures also, and he has hypoxemia, and we are managing that with invasive ventilation. Maybe
okay.
let us say after day two or so, if the ET secretion is having blood, should we consider now that post trauma ARDS may be DH, or how to differentiate it from lung contusion, sir? Like, is there any specific way? Just the lung contusions causing
Okay.
this?
Okay. So one of the things that will, okay, so post-trauma in itself is a big topic there. It's a good question. So you're having like a patient who's post-trauma with hypoxic respiratory failure with bloody returns on the ET. That's basically what you're saying, right? So there again, you're going to have multiple things. One is CT radiology is actually going to help you because if you're looking at trauma related ARDS, right? So trauma related ARDS is kind of different from sepsis related ARDS in the sense that trauma related ARDS is usually more mild and more responsive to positive pressure therapy. So if you look at the radiology, it is not going to be very dense consolidation and so on. If you're looking at lung contusions, that you can actually, based on the mechanism of injury, whether they actually got hit in the chest, where they got hit. So the confusion usually happens at the area of trauma. They're going to be subpleural in location most of the times, and they're going to be dense or either rounded or localized consolidation type with some background bilateral things. So radiology can actually help differentiate the two, although sometimes it may be very difficult. Again, if you're having a consolidation, you'll always be thinking whether this bloody return is a contusion or an infection. But anyway, it's again going to be difficult to differentiate, and you'll have to, empirically give antibiotics. So at the end of management of all of these patients, very unlikely that you are going to go home and sleep saying, oh, okay, I diagnosed this patient with this disease. It's always going to be a probability game, right?
Okay, sir. Yeah, got it, sir. And is there a possibility of the shear stress also causing like multiple lung contusions, which can mimic like ARDS, like multiple areas of
Yeah,
contusions?
yeah, of course, of course. Yeah, that can happen, definitely.
And the other doubt being in the acute exacerbation of ILD or IPAF,
Yeah.
can it be just the new community-acquired pneumonia presenting with hypoxic like respiratory failure? Like how to differentiate that from, because the one for one the treatment is steroids and the other one the treatment is antibiotic. Is it only retrospective diagnosis based on treatment response to antibiotics, or how is it so?
Okay, so yeah, so that's again a good question. Again, community-acquired pneumonia most likely is going to have like localized consolidations. And like I said, when you're doing a bronchoscopy, you're going to have like neutrophilic cytology or even minibul neutrophilic cytology, and you're going to get cultures positive. If you're having like an acute exacerbation of ILD, especially CTD ILD and so on, most of the times you're going to have the bile to be slightly lymphocytic. Okay. And if you think, okay, so community-acquired pneumonia is always a possibility. But again, if you see some things on the radiology, maybe some esophageal dilatation, some, bilateral pleural effusion, or if you think they give some vague joint pains, it is always good to do a serology over there. Okay. But if the pneumonia itself is the trigger, you'll have to treat with antibiotics as such. And the CTD diagnosis will actually come later. So you're going to treat with antibiotics first. And then you see that the patient gets better, but not completely better. That is when you're kind of looking at non-resolving ARDS kind of territory. That is when you start thinking, okay, it can be something else. And that is when you test for serology. All of the investigations need not always happen on day one.
Yes, sir, got it. Actually, this question I asked because I right now having a patient of already diagnosed IPAF,
Okay.
and he was on steroids and MMF, and MMF was stopped about 2 months ago because he had one more episode of pneumonia-like presentation.
Okay.
And at that time, he was treated with broad spectrum antibiotics with the atypical microorganism coverage also. And within 10 days, he came now again with the type 1 respiratory failure. So
Okay.
this time we were thinking about like maybe PCP is also possible in that sorts. And now I just attended this, and also you mentioned about acute exacerbation of ILD itself can be a possibility. He doesn't give history of fever, but he's already labeled like previously worked up entirely, and he's both chronic thromboembolism as well as ILD and
Okay.
severe pulmonary hypertension patient. And
Okay.
recurrent, he has come now second episode of respiratory failure with yes sir, requiring non-invasive ventilation. And because of that, the like we are not able to get the bal because non-invasive ventilation, so there's some practical difficulty.
Oh, okay. Yeah, no, that's a very difficult patient you've actually described. So again, immunosuppressed, you'll have to look at PCP and viral exacerbation, varicella, CMV, so on. They'll anyway come back. So bacteria, you're anyway going to treat, right? So when you're looking at acute X of ILD, even if it is because of an infection, what happens is the infection is going to be localized. But then the acute X itself will present as bilateral diffuse ground glass opacities and so on. Okay, so that may help, radiology may help. And again, if he has severe pulmonary hypertension, it can again be just, on and on fluid overload kind of situation that's happening. So you'll have to look at everything and optimize most of it. I probably think that, it might be difficult to pinpoint one thing in this patient, but you'll have to optimize a lot.
Okay, sir, thank you so much, and the talk was really informative, sir. Thank you so much.
Oh, yeah, thank you. Wait, I think Vikas has asked something. Sir, can we give empirical steroids in all suspected ARDS as there are, as there are many ARDS mimics which are being missed and many places can't. Yeah, okay, of course, you can give empirical steroid, but like I said, the diseases that we're thinking of as ARDS mimics will respond to much higher dose of steroids, like pulse steroids. And that is something I would not be very comfortable just giving empirically. Maximum, what we do is if we really think, okay, we have nothing else, we might give 1 mg per kg steroids maximum. So that is what we usually do. But higher than that, it would be a little difficult. Of course, all of this would be under cover of antibiotics.
Dr. Sujit, there is one more question
Sir.
about about interpretation of ball. So if the patient is already on steroids,
Uh,
so how will you interpret the ball eosinophilia or lymphocytic ball?
this is a So this is why the problem of diagnosing ARDS mimics come, because most of the times the ball gets delayed, right? So once that happens, you're actually kind of stuck. You don't know what to do, and you'll have to just go by clinical judgment and what you have. Ideally, what happens is as soon as a patient comes in, you see that okay, they're on low flow oxygen or even intubated. You directly do a ball within 2 days. That decision for BAL has to happen very early. And, it's not bad to involve everyone on this, like especially a pulmonologist. Just talk to them and tell them you need a BAL, you don't know what is happening, especially if you're not able to find risk factors, sir. But once you do give like antibiotic steroids, BAL interpretation becomes extremely difficult.
And at what oxygen requirement or ventilator requirement you will be comfortable doing ball? Many of the times this is the problem that people say that the oxygen requirement is quite high, so
Huh,
they defer the ball. So
right.
what
So if the patient is on low flow oxygen, we usually do a BAL on HFNC because we usually do a BAL on HFNC. If they are on HFNC or NIV, we kind of preemptively think about intubate because we don't like to delay this diagnostic window period. In such cases, we usually intubate and then do a BAL. Post intubation, we usually we are more comfortable doing a bronchoscopy and BAL if it is like FiO2 requirement is less than 60-70%. Beyond that, we usually kind of try and avoid it because the patients desaturate very quickly. And all of these BALs for such hypoxic patients would be very quick, no airway assessment, nothing. Very early on, you identify in the imaging, okay, you're going to do BAL from this segment. Quick, go in just to that segment, put in whatever you want, and then come out. But once you put in a BAL and you see that it is coming out as bloody, it is important to not stop there and do the multiple aliquots thing, because that is usually how DAH is diagnosed. And if you don't do the multiple aliquots on the first time, you're stuck. You don't know whether to give steroids or why it is bloody and so on.
so if someone has a bland hemorrhage,
Huh,
like
sir.
in trauma,
Huh,
do you
sir.
still get that multiple aliquot serial dilution of blood we are saying, or it will be blood completely?
No, sir. We will still get the serial thing.
Even
We
in the bland hemorrhage because of coagulopathy.
Yeah. We even in the bland thing, we still get that, but the other things will usually point out towards it. Either they'll be leukemic, very thrombocytopenic, or they'll be on anticoagulants and so on.
Yeah. Wow, it's an excellent session, Sujay. Actually, I had to tell you that last time you had a session like this. One of our residents diagnosed a pulmonary vena occlusive disease nephropathy.
Yeah, she got back to me. That was so nice to know. Yeah.
So thank you very much for accepting our invitation and spending your Sunday with us.
Sorry,
Next time
thank you, sir.
onwards, I will try to keep it
Anytime.
on weekdays.
Yeah.
If there are any other questions, people can actually mail it to centerforIQ@gmail.com. I will forward it to Dr. Sujay and I'll send you the answers back.
Yeah, that
Thanks
sounds
a
good.
lot. Thanks,
Yeah.
Sujay. We'll close the session. Yeah,
Yeah. Thank you,
great.
sir. Thank you all.
Thank
Bye.